Hello.
Hello.
A very good afternoon to all. Could you able to hear me? Very good afternoon to all who are present here. I'm really privileged to introduce our teacher and experienced hand therapist, Mr. Sathish Karunanidhi. Thank you so for your acceptance of our request and sharing your practical knowledge to our students. Mr. Sathish has graduated as an occupational therapist um, from Santosh College of OT and completed his master's in musculoskeletal condition from Manipal University. He worked as an assistant professor in SRM for 3 years. Then he moved to Australia and worked in public hospitals and running his own private hand therapy clinics in Harvey for 9 years. And I would like to share some sweet memories with you, sir, when you are a teacher during our MOT. I still remember those days that you always insisted us to be thorough and be strong in the basics, especially in anatomy and biomechanics. We used to sleep with the bones and books that time. And but really that helped us to be strong in the in our basics and practical. So thank you, sir, for being strict and as a very good teacher and who teach us basic knowledge about the anatomy and the biomechanics on all the musculoskeletal disorders, conditions, and all those things, sir. Now, I hand over this session to Sir, Mr. Sathish. Please take over, sir. Thank you, sir.
I hope you guys can hear me.
Yes, sir.
Okay, it's a great pleasure to come back to teaching. This is doing it after a long time. I would like to thank you for Punita to organize in a very short notice, and I would like to thank the principal of Savitha College of Occupational Therapy, Mr. Arun Kumar, for having me here. It's a Saturday afternoon, Saturday evening here, around 5:45. It's a relaxing time, and it's wonderful to have a talk about some hand condition. I always love talk about hand condition. The place I'm sitting right now is my home, but this place I also have a private practice at my home. This is my clinical setting that I'm doing it right now. So let's move on to presentation. I would like to go for entire screen and share. Okay. Can you all see this? Police, I just want to check. You guys are seeing the screen now?
Visible.
Punita, I just want to check. You guys are seeing the screen?
Yeah, it is visible, sir.
Okay, not a problem. Okay, so let's talk about ulnar collateral ligament injuries, which is very common in sports injuries, very common in the thumb. Basically, the thumb is a king of our hand, which means 40% of our hand function coming from our thumb movements. Thumb has got a most mobile saddle joint in our hand component, which means that injuries are quite common to thumb, including the ligament injuries and fracture. So I would like to go ahead with this taking assessment and management of acute ulnar collateral ligament injuries of the thumb. One of the commonest differences between apes and human being is because in apes they have useless thumb, and in a human being we have a very useful thumb. So remember how much importance the thumb right now, and also in the modern technology, modern world right now at this stage, we are using a lot of smartphones and iPads, iPhones, and technology. So thumb is playing a very enormous role in terms of mobility as well as stability. So it's very important to talk about the stability of the thumb. In case of any injuries to the stability of the thumb, how much it is going to affect our day-to-day activities as well as our functions and our work activities. Today, in this presentation today, we would like to talk about the overall outline of the presentation would be the incidence, anatomy, clinical presentation and assessment, diagnosis, which includes applying X-ray, applying films, stress testing test, ultrasound, MRI, arthrography. And we also can talk about classifications of ulnar collateral ligament injuries and associated injuries and differential diagnosis. And in the last one, management. Okay, incident. This presentation is mainly based on Australian population. It could be different in Indian context. basically in Australia, in any part of states in Australia, if any conditions like a ulnar collateral ligament injuries can be identified very early stages, because everybody's playing sports, everybody's playing part of the sports activities, which means that anything happens in terms of thumb dysfunctions, they'll come back to the doctor as soon as possible. But in an Indian context, it's been almost 10 to 12 years. I don't know whether that in Indian context, the orthopedic surgeons or general physicians, or what we called as a normal doctors, refer cases to a hand therapist or a physiotherapist for a management of ulnar collateral ligament injuries. In here, 50 per 100,000 individuals, they got ulnar collateral ligament injuries. 10-fold more frequent than radial collateral ligament injury, which means that very common. Ulnar collateral ligament injuries are very, very common in any part of hand function. Originally, this ulnar collateral ligament injury is termed as a gamekeeper's thumb for a chronic injury. In an acute injury, they call it as a skiing thumb. Most frequently skiing injury, which is mainly going back into European origin. But in Australia, we have a lot of games like playing cricket, playing a netball, playing a basketball, any sort of contact sports includes 6 to 9.5% of injuries to ulnar collateral ligament injuries. Often missed in emergency departments with failure to identify 55% to 64.3% of injuries that required a surgical repair. That's because this is a ligament injury. In emergency department, according to the triaging, they do very serious X-ray, but they don't have ultrasound facilities in emergency department. And then doctors in an emergency department, they have less appreciate that kind of injuries in the ED, emergency department. So identifying that kind of ulnar collateral ligament injuries in early stages are very uncommon in the emergency department. If managed inappropriately, like if you don't get treated, it leads to ongoing instability of the thumb, which means you can't hold your mobile phone, you can't hold the laptop in your hand. That always feels instability. Pain is one of the ongoing symptoms. Pain leads to swelling leads to stiffness of the thumb, and loss of grip and pinch strength, and most importantly, dexterity coming from the thumb will be affected, and which leads to, if you don't get treated this one, there might be possibilities that this condition can lead to early joint degeneration, which is osteoarthritis. So as Punita said, let's go back to anatomy. Anatomy and biomechanics are the basics of practicing hand therapy, because we have many areas of occupational therapy, including acute care, including a medical ward, a surgical ward, mental health, pediatrics, community, all. But in a hand therapy, it's all based on how thoroughly you guys are doing in anatomy and biomechanics, how good you understand the conditions much better. So let's coming back to the anatomy of the thumb here. MCP joint of the thumb is one of the synovial joints between metacarpal and proximal phalanx. Capsule of the joint is a fibrous structure reinforced by the volar plate. Volar plate is connective tissue along with the radial collateral ligament and ulnar collateral ligament. So understanding about the role of volar plate and collateral ligaments are very important to understand the injuries of the thumb. Volar plate assists the accessory collateral in stabilizing thumb in abduction. So as I said, that ulnar collateral ligament injuries are very common because we have to spread, we have to abduct the thumb to catch, to hold, to stand, to disc anything. So which means if the force is involved, the pressure is involved in abduction, there is a potential chances that there might be a tear in ulnar collateral ligament. When MCP joint is in extension, that's what the injury happens. Ulnar collateral ligament, it provides a stability against radial deviation and consists of two parts. Any ligament, if you take it into the fingers, it always have a two parts. One is a proper collateral ligament, which is arising from the dorsal third of the metacarpal head and inserting on the olar aspects of the proximal phalanx. And the accessory collateral ligament, or a secondary to ulnar collateral ligament, is arising from the MC metacarpal just olar to the proper and inserts along the ulnar edge of the olar plate. If you look into proper collateral ligament and accessory collateral ligament, is just doing the function opposite, which means the role of the proper collateral ligament is relaxed in extension and tight in flexion, taut in flexion. And in contrast to that, accessory is taut in extension and relaxed in flexion. So this is very important when we are assessing the thumb. We have to assess in two different action of the thumb. One, the thumb inside the hand and insert from, which means the leverage system of the intrinsic muscles are very less, which means it's provide more stability of the hand component. At the same time, allows the mobility of the thumb in terms of gripping, pinching, and the dexterity. Adductor pollicis lies superficial to both section or part of the